So we were looking at the functional classification of joints, which includes synarthrosis and amphiarthrosis and diarthrosis or synovial. Synovial joints have two endings, so it happens only in the appendicular skeleton, so it has two endings of the adjacent bones. One will be the proximal for the lower bone, and then the distal for the upper bone that articulate. And they have a pad of cartilage in between, which will be articular cartilage. This articular cartilage is hyaline, and this articular cartilage prevents the distal ending of one bone with the proximal ending of the other bone to have direct contact and then prevent friction. Bone is very hard, and then if you have this friction just between the movement of the two bones, then the bones will shorten. Actually, this can happen, but it happens during disease. Like for instance, someone may have rheumatoid arthritis or can have osteoarthritis. And in this case, you have worn out this cartilage, and then the articulations tend to shorten just because there is no pad of cartilage there to protect. So that's one component. The other component is having this fluid, which is the synovial fluid, that acts as well to cushion and preventing this bone-to-bone contact. This is made mainly out of hyaluronic acid, and it is produced by the little membrane that surrounds the two endings of the bones. That's called the synovial membrane. This synovial membrane is made of squamous cells. It's only one layer, and these cells are the synoviocytes. These cells can be attacked by the immune system, and then these cells get destroyed. You don't have production of this fluid, and then that's how you end up with rheumatoid arthritis. Because you lose the fluid, then the bones getting closer to each other, and then they erode. And then outside of this membrane, we have a capsule made out of strong collagen fibers to protect this membrane, which is very thin. So it's like a double wrap. The internal will be the synovial membrane, and the external will be the capsule. And the fibers of the capsule actually fuses with the periosteum on the proximal and the distal ends of the bones. Okay. And then functions of the synovial fluid besides lubricating, it's actually nourishing this articular cartilage. So you can imagine then if someone has rheumatoid arthritis, they don't lose that fluid, the synovial fluid, from day to night. It happens gradually. But as they're losing fluid because the cells of the synovial membrane are destroyed, then as this fluid is getting less and less inside this cavity, then this pad of cartilage is not nourished, and then this pad of cartilage becomes thinner with time, and eventually they end up with deformities, especially in the carpal area and the metacarpal carpal area. They end up with fingers that points laterally or medially, or in the anatomical position, of course. And then some articulations, the ones that are more movable, like the shoulder joint and the knee joint, have extra pouches with synovial fluid that we call bursae. So then they don't actually connect directly to the capsule or to the synovial cavity by themselves. They act like a leopard outside of the articulation that helps for preventing damage from external structures like the tendons that can be sliding. Like we have the tendon of the biceps that slides over the glenohumeral joint. And then we have a bursae there that helps for the smooth movement of our tendon, the upper tendon of the biceps brachii. So here are the different structures then of the joints. We saw this before. So this is the distal end of the proximal bone, and this is the proximal end of the distal bone. And this is the articular cartilage. Here is the space, the synovial cavity with the synovial fluid. And this is the membrane, the synovial membrane, all in blue color. And here we have the capsule that fuses with the periosteum of the bones. And then the degenerative conditions, as I was explaining before, like osteoarthritis or rheumatoid arthritis, makes these bones to get in contact with each other, and then you have damage. Now, differences between synovial joints, fibrous joints, and cartilaginous joints. Well, the only one that has a capsule and it has a cavity will be synovial. And then for fibrous joints and cartilaginous joints, they both lack cavities. And when it comes to function, they have less function, less movement than the synovial. So if you have fibrocartilage, you have an amphiarthrosis. Okay? Then with amphiarthrosis, you have limited movement. Now, for synovial joints, the synovial joints, just because they move a lot, they are the less stable. And they are the ones that dislocate much easier, especially the shoulder joint. And they are the ones that wear out the most, especially the ones in our hands, and also our knee joint. So cartilaginous joints, in general, offer limited flexibility and help us to absorb shock, like in the case of symphysis. So any questions? Okay. Now let's look at individual joints. Let's look at the shoulder joint, which is called glenohumeral. It's called glenohumeral because it happens between the head of the humerus and the glenoid cavity of the scapula. So just remember, this joint, it is the most movable, and the glenoid cavity of the scapula is shallow, so it's easy for dislocate this joint. And another bone that is nearby that indirectly helps to stabilize the joint will be the clavicle, but it's not precisely part of the joint. And now, this joint is classified as multi-axial and ball and socket. Ball and socket because it happens between the head of the humerus and the glenoid cavity, which can be compared to a socket. And multi-axial, it is classified as multi-axial based on the movement. It can move in all directions. It gives you 360-degree movement. Okay. Now, for the ligaments that helps to stabilize this joint, there is a ligament that goes between the coracoid process and one of the tubercles of the humerus. So this will be the coracohumeral ligament. And then we have the glenohumeral ligaments that goes between the rim of the glenoid cavity and the humerus. And then we have a set of muscles that are called the rotator cuff muscles that helps to stabilize this joint, like the supraspinatus and infraspinatus, that are posterior muscles that are located above the spine of the scapula and below the spine of the scapula. So those are supraspinatus and infraspinatus. And then just below this, we have the teres minor. Teres minor is a muscle that is round, and it's just located below this infraspinatus and together with the subscapularis, which is located anteriorly in the subscapular fossa, just anterior to the supraspinatus and infraspinatus, it helps to stabilize this joint. So those are muscles that helps to stabilize then the glenohumeral joint. And then for bursae, we have the subacromial bursae that is located below the acromion, and then the subscapular bursae that is located anteriorly just near to the subscapular fossa. And then this joint gives mobility but less stability. So here are the different movements that you can produce with this joint. You can produce flexion, 180, extension, 50 to 60 degrees, like this, abduction, 180 degrees, like this, adduction, 50 degrees, medial rotation, 70 degrees, this, lateral rotation, 90 degrees, and then all the combined movements will be circumduction. So here are the different components of this joint that can help to stabilize. So we have this coracoacromial ligament. So this is the coracoid process of the scapula, and this is the acromial process. And then in here, below this ligament, we have the subacromial bursae, and here is the glenoid cavity, the head of the humerus, and this is the tendon of the long head of the biceps that runs here in the intertubercular sulcus between the greater and the lesser tubercle. And then here, underneath, we have the fibrous layer of the articular capsule. So we already saw all of these, the rotator cuff muscles, and for these ligaments, the coracohumeral ligament, it is only one ligament that connects the coracoid process to the humerus, and then it helps to support the weight of the arm. Now the glenohumeral ligament is subdivided into three, the superior, middle, and inferior, and this one reinforces this anteriorly. The most common type of dislocation of the shoulder joint, it happens inferiorly because we don't have as much support. And then for the subacromial bursae, reduces the friction between the acromion and the rotator cuff tendons, and the subscapular bursae, it facilitates this motion of the deltoid muscle over the joint. Now, not only in the glenoid cavity, but also in the acetabulum, we have a rim of cartilage that surrounds these cavities that is called the labrum. So, especially here in the glenoid cavity, we need to have a labrum or a pad of cartilage that looks like almost like half moon. And this one, it is located more inferiorly because that's where the head of the humerus will tend to fall more when the bone dislocates out of the glenoid cavity. So it's a rim of fibrocartilage that helps to deepen this cavity. And here it is. So this is a better view of all of these different components that helps to stabilize this joint. So here we have again the subacromial bursae, and this will be the subscapular bursae. And then here we have the coracoid process, and this is the humerus, the area below this greater tubercle. So this will be the coracohumeral ligament. And then in here we have the tendons of the subscapularis muscle, and this is the tendon of the long head of the biceps. And then here, in this view, you can see this connection of this tendon between this coracoid process and the greater tubercle of the humerus. So this is the tendon of the supraspinatus muscle. So this tendon and the coracohumeral ligament helps to prevent the head from going anteriorly. Now, inferiorly here is where we have the weak point, but we have this labrum. So the labrum is this. This is basically the lateral side showing you of the shoulder joint when you remove this head of the humerus, so that you can see here the glenoid cavity itself, and this pad of cartilage will help us to reinforce this to make it a little bit deeper. So this is the labrum. And then here is the posterior view. What muscles do we have that helps to stabilize this joint? So we have the supraspinatus, which is this, that connects into here, into this greater tubercle, the tip of the greater tubercle. And then here we have the infraspinatus, and this is the teres minor. So they reinforce this articulation here inferiorly. And then the subacromial bursae, it protects this articulation so that these muscles do not connect directly into the acromion, which is the extension of the spine, which is this. And this is all then the parts that helps to stabilize this joint. Now for the elbow joint. So the elbow joint, it is the joint between the distal part of the humerus, the ulna, and the radius. So this joint is hinged, and it is uniaxial, allows us only to do flexion and extension. And we have an articular cartilage that covers the distal part of the humerus, the trochlea. And then we have the trochlear notch of the ulna that also has an articular cartilage, so that you can slide the ulna over the humerus to make flexion and extension. Now, there is an articulation between the head of the radius and the radial notch of the ulna, proximally. So that's the proximal radio-ulnar joint. And in this case, this joint helps us to do movement of our palm down, which is called pronation, and movement of our palm up, which is supination. And we have a capsule that encloses the humerus and the ulna and the humeroradial articulations. The radius itself, the head, in the most proximal part has a concavity. That concavity actually fits the convexity of, if you remember, of the capitulum. And because of that, you not only can do this type of flexion and extension, but also at the same time you can supinate or you can pronate. People who lift weights, when they're working out this muscle, the biceps, they do this movement, flexion and extension. But if they want to work out better their muscle, they also supinate. They do this. And this is given again because we have a concavity in the head of the radius that fits the convexity of the capitulum in the distal part of the humerus. So we can do this type of movement, pronation, supination. So now, what ligaments helps to stabilize this joint? Well, here in the lateral portion, we have the lateral collateral ligament or radial ligament, radial collateral ligament. And then medially, we have the medial collateral ligament or the ulnar ligament. So it has two names. Radial because it's on the radial side, ulnar because it's in the ulnar side, and it's lateral and it's medial. And then there is a ligament between the head of the radius and the ulna, which is the annular ligament because it's almost like a ring, that helps to stabilize the head of the radius in the ulnar notch. Sorry, in the radial notch of the ulna. And then sometimes there can be some dislocation of the head of the radius over this ulnar, of the ulna, over the ulna, when in a little child, when the mother or the caregiver grabs the child with the arm extended and pulls the forearm. So it can pull the head of the radius out of the radial notch of the ulna. And now, what muscles and tendons stabilize this joint? Well, we have the biceps anteriorly with the lower tendon of the biceps that inserts into the radial tuberosity and in the ulnar tuberosity. And then we have posteriorly the tendon of the triceps brachii that helps to stabilize this articulation posteriorly. So we have then these tendons that crosses the elbow joint. And then this one allows flexion and extension, but also pronation and supination. So flexion or bending, it is moving your forearm closer to the arm. That will be between 140 and 150 degrees Celsius. Sorry, degrees. I was thinking temperature. So then here we have the radius. This is the ulna. This is the coronary process of the radius, and this is the head of the radius. The head of the radius fits here into the radial fossa. So this is the anterior view. So it fits here into the radial fossa above the capitulum. And then this is the trochlea. And here is the trochlear notch. This is the lateral view of the trochlear notch, which you can hardly see here, but this is the coronary process. So the coronary process slides over this trochlea and then fits into the coronary fossa. So then you have a stop. So you flex, and then that's your stop. You cannot go beyond that. Okay? Now, posteriorly happens the same, but that will be for extension. So here is the olecranon process, and then this is the trochlea, this is the trochlear notch, this is the coronary process, so this is the lateral view. And here, in the posterior part, above the trochlea, from the humerus, you have the coronary fossa. Sorry, the olecranon fossa, which is the largest fossa that fits the olecranon process. So then extension ends in there. So you cannot rotate your forearm like this. So you fully extend and that's it. Why? Because this one fits into here and there's no more movement. So extension is 0 degrees. And then pronation, which is rotating the forearm so that the palm faces down, that is between 70 to 90 degrees. And then supination, which is bringing your palm up, is 80 to 90 degrees. So pronation is like if you were about to dump something, and supination is like if you were asking for soup. Supination, moving your palm up. Okay? So those are the couple of movements that can be also done with the with the elbow. Now, components of the wrist joint, the intercarpal joint. So remember, we have 8 carpal bones arranged in 2 rows. So we have the proximal row and the distal row. And we have a scaphoid, lunate, triquetrum, and pisiform in the proximal, and then you have trapezium, trapezoid, capitate, and hamate in the distal row. These joints that we have here are classified as plane or gliding. The facets in each of these bones is very smooth, so they can move a little bit over each other. So this is a gliding movement. And these bones have an articular cartilage that covers the carpal bone surfaces, and that help us to have a smooth movement between these bones. Now, we have, of course, a joint capsule, as any other synovial joint, that is very thin, that helps to stabilize together with some ligaments, the small movements that we have. Like we have in our posterior region, we have the extensors, the tendons of the extensor that helps to stabilize the carpal bones. And then anteriorly, we have the tendons of the flexors. So with the flexor, we flex our carpi. With the extensor, we extend our carpi, and also the fingers. We can flex them or we can extend them. So what ligaments do we have? We have the palmar and dorsal radiocarpal, and then we have the intercarpal ligaments. And then I already told you about these tendons, the flexor and the extensor muscles. And we have then this gliding movement that allows flexion and extension, but also bringing the wrist toward the medial part of our body, which will be adduction, ADD, or bringing it away, which is abduction, ABD. ABD, abduction, like this, but in this case it's going to be our hand, and adduction. We can do this, princesses, right? But they use those tendons. So flexion is 80 degrees. Extension 70 degrees. Radial deviation, which is abduction, like this, 20 degrees. Ulnar deviation or adduction, 30 degrees. So 20, 30, and then 80, 70. So here is then a view of all of these bones. So we have a scaphoid, lunate, triquetrum, pisiform is underneath, and then trapezium, trapezoid, capitate, and hamate. And here is the articular cartilage between them, which you can see here, and then you have gliding movement. And now it's not seen in here, we will see it in the muscular system chapter, but the carpal bones, they form like a little tunnel when you see it anteriorly, like this, or posteriorly like this, forms like a little tunnel. Through this little tunnel, we have ligaments that passes through there and a nerve that is called the median nerve. When someone types a lot, these ligaments that we have here can be worn out and the tendons can be inflamed. That can cause compression of the median nerve. And this is known as carpal tunnel syndrome. When you have compression of these nerves, you will have numbness and you have pain and weakness. So remedy is to perform surgery and to free up a little bit a membrane that we have there as well that is called the retinaculum. And that will help to free up a little bit this nerve, and the person will have relief of the signs and symptoms. Any questions about the wrist joint? Now for the knee joint. The knee joint is the most complex joint that we have in our body. It is formed by the femur, the tibia, and the patella. The fibula, it is not part of this joint. This joint is a modified hinge joint. It helps you to have biaxial movement of flexion and extension and slight rotation. It can be medial rotation or lateral rotation. And we have articular cartilage between the femur and the tibia. And this covers the condyles of the femur, the plateaus of the tibia that are found in the tibia condyles in the superior portion, and in the posterior region of the patella, in the medial and the lateral surface that articulates with the patellar surface of the femur. In between the femur and the tibia, we have pads of fibrocartilage that we call menisci. We have a medial meniscus and a lateral meniscus. Meniscus is singular, meniscus plural. The medial meniscus, it is attached to the plateau of the tibia and also to the medial collateral ligament. And because of this, when someone receives a physical injury on the side of the knee joint, the person can break this medial meniscus and also this medial ligament, okay, with a tackle, for instance, in football. And then we have in the lateral side of this joint, we have then the lateral meniscus and the lateral collateral ligament. And then, of course, we have a joint capsule that it is very thick, made out of collagen fibers. And then we have the synovial membrane. Another name for the collateral ligaments will be, for the medial ligament, will be tibial. Why? Because that's where we have the tibia. And then for the lateral, it's going to be called fibular. And then we have in between the intercondylar eminence, that is part of the tibia, and the condyles of the femur, we have the cruciate ligaments. We have two, anterior cruciate ligament and posterior cruciate ligament. The anterior cruciate ligament runs between the anterior part of the joint into the posterior lateral part. And then the other one, the posterior ligament, it runs from the posterior part to the medial anterior part of the joint. And these ligaments can be tested by the anterior drawer test. So in this, or posterior drawer test. So in this case, you will have the person sitting, and then the person's foot, it has to be more or less not very stable in the ground. It can be like in an exploration table. And then if you want to do the anterior drawer test, all you need to do is grab the tibia and the fibula, the leg of the person, and then bring it up, bring it towards you. So it's like pulling towards you. So that's the anterior drawer test. If you have a lot of movement, more than likely the anterior cruciate ligament is damaged. That's the one that prevents the sliding anteriorly of the femur over the tibia. And then for the posterior drawer test, it is the opposite. You push the tibia and the fibula. And then if you have a lot of movement, so like if this is anterior, this is posterior, then your tibia will slide over the femur like this. That is a positive sign for the posterior drawer test. And then we have another one, it's called Lachman's, that tests the anterior cruciate ligament. But in general, you shouldn't have a lot of movement between the tibia and the femur. Now, the tendons and muscles that stabilizes this joint will be the tendons of the quadriceps anteriorly, which is this muscle in here. It has 4 heads, that's why it's called quadriceps. And this, it's a big extensor for knee joint. So this has a tendon that runs over the patella and then inserts into the tibial tuberosity of the tibia. And then we have the patellar ligament then, that it is the continuation of the quadriceps tendon. So movements of this joint: flexion, extension, and then medial rotation and lateral rotation. So flexion, bending the knee 135 degrees. Extension, like when you're standing, 0 degrees. Slight hyperextension is possible in some individuals. And similar for the elbow joints if they're double jointed. And you can have 10 degrees internally and externally. That's a slight medial rotation or lateral rotation. And then what helps to stabilize this joint as well is the menisci. The menisci has these surfaces in the pad of cartilage that corresponds, for instance, to the condyles in the femur. The condyles of the femur are convex, so these pads of cartilage are a little bit concave. So, and then the most common knee injury is an injury to the ACL caused by sudden twisting or stopping and twisting at the same time. So, here are the components of the knee joint. So this is the anterior view of the knee joint. This is the distal portion of the femur. This is the proximal portion of the tibia. So here is the medial condyle. Here is the lateral condyle. I cannot tell you right now specifically if I didn't have this, if this was the medial or the lateral, because I'm not seeing the proximal part of the femur. But anytime that you have an isolated bone, one of these bones from the appendicular skeleton, and you want to know which side is which, you always have to look, for instance, if it's the humerus or if it's the femur, you have to look at the head. The head always faces medially. So then, what I expect for this bone, if I didn't have this as a reference, is that if this is the medial condyle, then what you can expect to see proximally will be the head facing medially. Okay? And now, this is the lateral condyle, and this is the patellar surface. And here we have the intercondylar. Come on and sit.
Sorry, we're late. Come on in.
So this is the intercondylar fossa. And then here we have the tibia. The tibia has condyles as well, so this is lateral condyle and this is the medial condyle. And what is going to be your reference point for the medial condyles? Well, you look distally, and if you see the medial malleolus, then this has to be the medial condyle. And remember, the medial malleolus is that part of the bone in your ankle that you touch. Okay? So then this is the medial condyle. And then this part above the condyles is the plateau, and then in between you have the intercondylar eminence that cannot be seen because you have this anterior cruciate ligament here. But the anterior cruciate ligament then runs from the posterior part of the lateral condyle of the femur into the medial condyle of the tibia. And then the posterior runs from this lateral condyle of the tibia to the medial condyle of the femur. So then these two crosses, that's why they are called cruciate ligaments, and this is the one that tears most likely. And here we have the medial meniscus that attaches closely to this medial or tibial ligament. And when someone, again, receives a tackle here on this side or an injury on this side, this one breaks, and also this ligament in here. And then in here we have the fibular collateral ligament that connects the lateral condyle of the femur to the head of the fibula. And then here we have the posterior part of the patella with the medial surface and the lateral surface. And here is the patellar tendon, and this is a tendon of the quadriceps, which you can see here laterally. This is a lateral view. And then we also have bursae. So here we have the prepatellar bursae, and this is the infrapatellar bursae, helping together with these tendons and actually this fatty tissue that we have in our knee joint to stabilize this joint. Okay? Any questions?
I have a question. So when it comes to our joints and everything, you talked about being double jointed. What does it like mean medically? Like, are they missing a ligament? Do they have another, like an extra of something? Like, what causes it? The extra mobility?
There are different causes. We have the most common ones, which are collagenopathies or diseases of the connective tissue. We have a disease that is called Ehlers-Danlos disease, and then we have another one that, what is the name? Marfan syndrome.
Yeah.
So in this case, the collagen fibers are very elastic, very thin. And then because they're very elastic and very thin, they allow more movement than the regular thickness of a collagen fiber. And it's not very common, but it not only affects the joints. It's not very common to see these diseases, but not only affects the joints, but also can affect the heart valves. It can affect the arteries, like our arteries become very elastic, and they can have an aneurysm, for instance, a weakness in the wall of the arteries. So that basically allows more blood to go toward that weakness and inflates like a balloon when the heart is contracting, and that aneurysm can rupture and the person can bleed. Another thing that happens with people with Marfan syndrome, for instance, is that the retina detaches really easily, which is the membrane that helps us to see. And when a person receives a hit in the head, with very tiny, you don't have to even have a great hit in the head, but that actually can detach the retina and the person can become blind. I remember, and another characteristic of Marfan syndrome, for instance, they're very tall, their fingers, they are very long, and they have very flexible fingers. This is called arachnophilia. Good question. Any other questions? Okay, now let's talk about the hip joint or coxofemoral joint. So it happens between the coxal bone, which is this bone, and the femur, which is our longest bone in our body. So we have in the femur, the longest bone in our body, we have a head that fits the acetabulum. The acetabulum is a cavity in the bone, and then the head fits into there, and then you can have this type of movement, rotation, right? So you can do this type of movement with the coxofemoral joint. This coxofemoral joint, it is similar to the shoulder joint. It's a ball and socket, and it's highly movable. But because we have a lot of muscles here that help us to walk and stand still while we are erect, then we don't have as much movement as for the shoulder joint. So this joint is more stable than the shoulder joint. It still can dislocate it, but it's harder. In this joint, we have the articular cartilage that covers the femoral head and the acetabulum. And just like as for the glenohumeral joint or the shoulder joint, we have also a rim of cartilage, the labrum, that deepens this joint so that the head of the femur fits better into the acetabulum. And then we have also, as any other synovial joint, we have a capsule that protects the synovial membrane, that protects the joint, the bones. And we have ligaments that helps to stabilize the joint. So we have a ligament that goes from the ilium to the femur. So that would be the broader bone part from the coxal bone, which is this one. And then we have the pubofemoral ligament. We have the pubic bone in here, and we have the femur in here. So these two stabilizes the joint anteriorly. And posteriorly, we have the ischiofemoral ligament that runs between the bone that is where we sit, the ischium, and then the femur. So that's the ischiofemoral ligament. So these three ligaments then makes this joint to be more stable. And also we have muscles, like the gluteal muscles. The butt muscles, these ones are the gluteal muscles. They help to stabilize our joint. And also we have a muscle that runs between the lower vertebrae, the lumbar vertebrae, and the iliac bone that is called iliopsoas. And this muscle helps us to do this and also to do this. So this muscle stabilizes the joint anteriorly. And we have minor muscles like the gemellus muscles and quadratus muscles on the coxal bone that also helps to stabilize this joint. Type of movements that we can do: flexion, lifting the thigh forward. Okay, so that's 120 degrees. Extension, moving backward, 20 to 30 degrees. Adduction, 30 degrees, moving it inside. ADD, adduction, 30 degrees. And then you can have medial rotation, which is doing this, 35 degrees, or lateral rotation, which is 45 degrees. I'm not a dancer, and I always envy people who does this, but people who do this dance, I think it's called the four corners. It's a country dancing. My gosh, they use a lot the medial and lateral rotation, okay? So, and then you can do the combined movements, all of them. That's circumduction. This is circumduction, okay? And then this is the different parts of the joint. So this is the lateral view. So here we have the lumbar vertebrae, this is the sacrum, coccyx, this is the coxal bone, and this is the proximal part of the femur. So this is the femoral head, this is the neck, this is the iliac bone, ischium, pubic bone, this is the acetabulum with the articular cartilage here, and also the labrum that helps to make a little bit this deeper. And then in the middle part of the head of the femur, which is called the fovea capitis, we have this little indentation that connects a ligament that is called round. So this is the round ligament cut. If you have eaten chicken thighs, sometimes the chicken thighs can be attached into this coxal bone from the chicken, and then you pull away the thigh bone from the hip bone from the chicken, you will be able to see in the head a little ligament. That's the round ligament. And actually, this is something that I believe that I have heard before, which I don't know if it's true, but Jewish people, they don't eat chicken thighs. And the reason for that is because there's a part in the Bible, and this is, again, something that I have actually read about. There was this character from the Bible named Jacob that fight with an angel during nighttime. And then as the day came by, he was fighting with the angel to let Jacob go because he wanted to have a blessing from the angel, and the angel didn't want to give the blessing, and he was very stubborn, Jacob or Israel. So he was grabbing so hold tight to the angel, and the angel, just to let him go, he dislocated the hip from Jacob. And then from then on, he started to limp. And there is kind of apparently like a superstition from the Jews that says that they cannot eat that part of the chicken because of that. Okay, but I don't know. I cannot testify for that. But then that's the round ligament that you can see in there. And then this is the sagittal section of this joint. So you can see this round ligament in situ. So this is the acetabulum. This is the capsular tissue. And here are the ligaments. So this ligament is the iliofemoral because it goes from the ilium to the femur, same as this. And this will be the pubofemoral. The pubofemoral, it's a little bit deeper than this. And then posteriorly, we will have the ischiofemoral around this area. Any questions? Okay, so now, how does the shoulder and the hip joints compare? Well, the shoulder joint is shallower than the hip joint. And both of them have ligaments, but the ligaments in the hip are stronger. And we have more muscles around our hip joint than the shoulder joint. That makes the shoulder joint to be less stable than the hip joint. So then sometimes you have to sacrifice stability for mobility, and that's what it happens in our shoulder joint. Now, before we move on into the next slide. So every joint in our body receives blood supply. And we have arteries that provides blood supply to this joint. And when these arteries become occluded, there is no blood supply to this tissue. And what happens when a tissue doesn't have blood supply? The cells will die. So that is one of the characteristics of people as they age. They have occlusion of these arteries that provides blood supply to this joint, and they will have weak neck in the femur, and then when they fall and they don't hit it as hard, they break the neck of the femur. And the head of the femur itself, which is this, also can lack blood supply. And this type of problem is called avascular necrosis. So we'll be cell dead, and then avascular, lack of blood supply. So oftentimes, a broken hip bone is because it is lacking blood supply. And actually, the hip bone is not breaking, it's the head of the femur. And the neck of the femur, the one that it breaks. And then they can substitute. They can put a replacement in. And then comparison between the knee and the elbow joints. Well, both are hinge joints, but one is modified like the knee joint. With the elbow joint, you have flexion and extension, same as for the knee joint, but with this one, you can have this medial rotation and lateral rotation, and this one has menisci in between the bones so that you will prevent damaging the joint, and then you don't have menisci in the elbow. So now for a structural classification of these synovial joints. So we have plane or gliding, in which the facets are very smooth, so they slide over each other, the bones. It's a uniaxial type of movement, so only in one direction. You can have hinge joints, like hinges in doors, that allows flexion and extension. You can have pivot joints, like the one between the first vertebrae and the second vertebrae, which is the atlas and the axis. It's a pivot joint. It's also uniaxial, allows us to do this. So we have a part of the second vertebrae that's called the axis, and then we have the facet for the dens. It's called the odontoid process or dens, and then we have the facet for the dens that allow us to do this movement. Is the atlantoaxial joint, and when this dens breaks in a whiplash accident or someone falling in the head, that dens can go into the spinal cord and the person end up quadriplegic. So that's one of the examples of what can happen wrong with these joints. And then we have condyloid or ellipsoid joints, in which you have an oval part of the bone fitting into a shallow concavity. We have biaxial movements. We have flexion, extension, abduction, adduction. An example, we have it in the first metacarpal phalangeal joint, our thumb joint. Thankfully to this, we can text. We are the only ones in the animal species that can do this. Primates, they cannot do this. And other animals, they can do this. So that's what makes us humans, having this type of movement. So it's a condyloid joint. And then we have a saddle joint, which happens between the thumb and the carpals, and also between the carpals and the first row of phalanges, helping us to do flexion and extension. And then we have ball and socket, which we saw an example, like the shoulder and the hip joints. And the shape determines the possible movements. So with ball and socket is multiple directions, hinge only in one direction. So here is the classification of these joints. Gliding, smooth surfaces here. Hinge in the elbow. Pivot between the atlas and the axis, the atlantoaxial joint. This is the dens. Condylar joints here, in between the metacarpals and the phalanges. Ball and socket in the shoulder. And here is the saddle joint in the first metacarpal. So that was the structural classification. Now the functional classification, we already saw this before. It depends on where the movement happens. No movement at all will be non-axial. Movement in one axis, uniaxial, and two axes, biaxial, multiaxial, in multiple axes. So uniaxial joint, flexion, extension in the elbow joint. Here we have another one. So this case will be in one axis and a second axis. So you can do flexion, extension, and abduction, adduction, abduction, adduction. Multiple axes. Medial rotation, lateral rotation in the shoulder. Like this, or circumduction in this way, or broader circumduction. So it's a ball and socket. So now let's look at the names of the body movements. Flexion is bringing a part of our body close to the body. Extension, away from the body, okay? And then hyperextension. So with our head, we can look up, very up, that's hyperextension. That's hyperextension of the neck. Then we can have hyperextension as well of the arm. So this is flexion, hyperextension, and extension. Then we can have lateral flexion, like this, okay? And then lateral extension as well with our head. Abduction, adduction, and circumduction. Moving away from the midline. ABD, abduction. Closer to the midline, adduction. So this is adduction, abduction. And then circumduction, 360 degrees. Lateral rotation, medial rotation. Medial rotation, lateral rotation, medial rotation, lateral rotation. Opposition, reposition.
Sorry, we have stragglers.
Yes, bring them. Depression, bringing your shoulders down. Elevation, moving them up. Depression. We can do that also with our jaw. When we keep our mouth shut, that's elevation. When we bring it down, that's depression. And then our jaw also can move anteriorly, that is protraction, or posteriorly, that's retraction. Protraction, retraction. For our feet, if you bring it, the sole in, that's inversion. To the side will be eversion. And then if you move your toes up, that's dorsiflexion. And then if you stand in your toes, that will be plantar flexion. So I already told you about this before. So we have injuries, like knee injuries. So in this case, the person receives a hit here on the side of the knee, and that will tear the meniscus, also this ligament, like the posterior cruciate ligament, and the tibial collateral ligament. So here is a torn ligament with an MRI in the anterior view, and this is the sagittal view showing you a torn anterior cruciate ligament. So this causes instability of the joint and limited motion. For replacement of the knee joint, well, it happens because you break the head of the of the hip joint. You break the head of the femur, so they put a prosthetic replacement made of titanium, most than likely. And then they have to also carve a little bit of the acetabulum and put plastic there that helps to prevent this ball from the replacement to eroding the bone. People, after they have a replacement of the knee joint or the hip joint, they don't recuperate completely. They have a lot of limitations, and unfortunately, sometimes they have to have another surgery just to, because sometimes they don't adapt to a specific joint, so they have to have a second replacement. So who is more susceptible to this? Well, elderly, and especially if they have osteoporosis, which is when the bones are very fragile because they don't have enough calcium. So the fractures then can disrupt the movements like flexion, which is 120 degrees, extension 20 to 30 degrees, and rotation 35 to 45 degrees. So now for the preview of the next chapter, we're going to see the muscle types that we have. We are going to start naming the muscles, and we are also going to see the insertion and origins of the muscles. So let's look at these questions.